Very much, Mr Deputy Speaker. I first of all would like to just say Happy St Andrew's Day to all Scots across the parliamentary estate, whether born in Scotland or adopted Scots like myself. Obviously, we're here to talk about this new variant of concern, Omicron, and it's quite clear that we're in the early days of this and we need more research. But it is a heavily mutated variant, and looking at the mutations, it includes mutations that do suggest increased transmissibility and also mutations that are associated with immune escape. And that's what's causing the concern. We see cases surging in South Africa, but we do not yet have proof that those surges are directly related to Omicron. One thing that has emerged from South Africa is evidence of reinfection of people with previous proven COVID infections. And that's something that we haven't seen so often during the pandemic. Just to respond to the member for Altrincham and Sale West, I would have to say he talks about people's freedom to choose what they do, but the person they might infect actually has the choice removed from them, particularly people who are immunosuppressed or who are vulnerable. It is a network, and if you've ever seen that little GIF where someone drops a ping pong ball onto mouse traps, you will realise the way things spread. You may have a choice. I, as an immunosuppressed person, may therefore not.
Giving way. Isn't exactly the same thing true of flu?
The thing is, we don't suffer the same deaths, hospitalisations or outcome from flu. Well, we don't. If you look at 170,000 deaths over the last 18 months in the UK, we certainly have bad flu winters where we can get up into the teens towards 20,000, but we've never got close to 170,000 over 18 months.
And I know the Honourable Lady has a great deal of medical experience, but obviously she's referring to a period when we didn't have vaccination. Am I not right in thinking that in a vaccinated population, the case fatality rate of COVID is not actually remarkably different from that of influenza, once you've got a vaccinated population?
Well, we are actually still seeing hospitalisations and deaths in people who are doubly vaccinated. The reason we're delivering boosters in all 4 health services is because that immunity is waning. What we're concerned about with Omicron is if it is able to immune escape, it could push us backwards. And therefore, we simply don't want it to become re-established and undermine the achievement that vaccines have made. And things like masks and hand washing, which were reviewed in the British Medical Journal that the member for South West Wiltshire referred to, it showed that masks had as big an impact as hand hygiene. So surely we should be doing both. And both of them have no major economic impact. You're not talking about locking down, you're not talking about shutting businesses, you're actually talking about everyone trying to protect everyone else, actually so that they can continue to be active and continue to be out in society. Now, it's important to remember that even if our current vaccines were shown to be less effective against Omicron, that doesn't mean they would have no impact. And it's important to realise that we already see that impact on Delta with regards spread, where actually the reduction is only about 50%, but it has markedly reduced hospitalisation and death. And we therefore would be still hoping for that with Omicron. So pushing vaccination, encouraging people to get boosted, remains as important as it always was, and Delta is still by far the most dominant variant circulating in the UK. There's no evidence as yet of differing symptoms or severity, but one of the weaknesses of the data we have from South Africa is the initial outbreaks were in students, and therefore young people already tend to get milder infections, and we don't yet know what Omicron will be like in an older or more vulnerable population. We do have one advantage in its diagnosis, and that's that the S gene, which is one of the 3 genes that's looked for in common PCR tests, is missing in Omicron. And that means rather than having to wait for genomic testing, which takes quite a long time, you get a heads up or an early warning on that PCR test that you've got this subgroup with S gene dropout, which means the chances are it could be Omicron. These patients could be warned. These samples can then be sent for full genomic testing. In Scotland, it's a retrospective review of recent PCR results looking for S gene dropout that has identified the 9 patients in Scotland. And I assume similar work is happening in the other nations across the UK. In contact tracing of the 9, there's no evidence of connection either to COP26 or even the South African rugby game. But of course, tracking continues. This does mean that PCR testing is even more important. Lateral flow tests, which we're all doing, hopefully, on a regular basis before coming here, of course can't detect variants. It's a simple yes-no that you do yourself. There's no access to take further analysis. And of course, lateral flow tests had been allowed as part of the travel testing. In the Netherlands, they tested 600 passengers arriving from South Africa and found 1 in 10 had COVID. Now, that's an incredibly high incidence, much higher than what we have anywhere in the UK. And a fifth of those were already Omicron. So Omicron is not just in Southern Africa, it's not just in the UK. Because of the use of lateral flow tests, it's probably already more widespread than we think. I therefore welcome that the government has returned to day 2 PCR testing rather than lateral flow for travellers and is quickly re-establishing quarantine. But they should have a PCR test before they travel. It's rather, shutting the stable door if you find someone's positive when they've just spent 8 hours on a plane with hundreds of other people. I'm happy to.
I thank the Honourable Lady for making way. Is she not concerned, as I am, that there is too much emphasis on PCR testing for tracking variants of concern? During a 3-week period in July, there were 500,000 PCR tests, 7,000 tested positive for COVID. Only 5% of those 7,000 were tested for variants of concern. So it's not quite the silver bullet on variants of concerns that she might hope it would be.
Well, I wasn't claiming it was, because genomic testing takes a couple of weeks, generally, and therefore, actually, you're too late to isolate. What I'm saying is that in this variant, as in Alpha, but not in Delta, there is this missing S gene, which means that on that initial test, which is taking 6 hours or the next day or whatever it is, you're already getting a heads up that you're dealing with a case of Omicron. You then can go on and do the genomic analysis, but you're already able to reply to that patient and say, we think you have this variant. You need to isolate thoroughly, and you need to isolate longer. I will.
I thank the Honourable Lady for bringing her medical knowledge to the House. It's very, very interesting, particularly on the SG gene. I don't know what magic goes on within a lateral flow test. We put the drips on one end and the one band hopefully appears and not 2. Could a lateral flow test be adapted to be specific for this type of variant?
I think you'd be talking about redesigning for a whole new antigen. It's actually just one of the advantages that we get from PCR. PCR is looking at genes. That's basically what it's doing. I'm not going to talk about the whole big long name of what PCR stands for, but you are looking at genes, and we're given this little advantage that is a benefit to us, that we already get that heads up. I don't think it is feasible in any reasonable timescale to change lateral flow tests. So I think we're lucky that this one has S gene dropout, and we will get an early warning. But one of the issues about only focusing on a day 2 PCR, and that if you are negative, you're then released, unlike what's being discussed for domestic isolation, is that the incubation period of COVID generally is much longer than 2 days. It has generally been reported as an average of 5 days and can extend up to longer than that. So that there's a real danger that if you have arrived in the UK and you may have had contact, you get a negative PCR day 2 and you go about your business, but actually it's false reassurance. And that's why the Scottish and Welsh governments have asked for a COBRA meeting to debate the evidence that is there on a 4-nation basis and discuss about having at least 8-day isolation for travellers, with a day 8 test being negative required before people could release. And the Prime Minister should listen to that, Because one of the issues we had in Scotland when we tried to maintain stricter and broader hotel quarantine is the majority of long-haul passengers arrive through hubs such as Heathrow. And therefore the devolved nations have no ability to impact on that. And we should be looking at trying, indeed working with the Republic of Ireland, to have the whole common travel area safer from the point of view of how we move about inside it.
Thank you very much, the member from Central Ayrshire. Just before she finishes, I'd just like to ask from this side, which obviously isn't as sparsely populated as the opposition benches, which I do welcome those that are here. But I presume, in speaking on behalf of the Scottish Nationalist Party, and considering what's happening later today, I presume your party is going to be, the SNP are going to be supporting the government when that vote comes forward at the end of this debate.
Well, this debate, and this is the reason why my colleagues are not here, this debate is largely about the regulations within England, and therefore, we don't normally vote on English matters. We haven't normally voted on your COVID regulations. But the one aspect is this around testing and isolation of travellers. So we support it. We just think it should go further. Now, with regards to domestic precautions, Scotland never got rid of mandatory masks. Basically on public transport, in shops and in schools. And what we haven't heard the Minister refer to is, are they planning to reintroduce mask wearing in schools? Because at the moment, with vaccination and its impact, what we're seeing is that the bulge and peak of cases is moving down and is in younger and younger teenagers and primary school children among those who are unvaccinated. So if it's not masks in schools, I would come back to, is there a plan to install CO2 monitoring? Is there a plan to install ventilation? How do we actually reduce the incidence in schools? I'm happy to give way.
She maybe just answered some of the question, but I just wonder if she might set out what her assessment of the impact of mask wearing in Scotland on case numbers. And is the case of the younger children, is it not just testament to how well we've done at keeping them apart and proof that we cannot hide from the virus when we do come back together?
Well, at the moment, it's very difficult. Cases go up and down and we swap positions. At the moment, Scotland has the lowest incidence at 349 per 100,000. Northern Ireland has the highest at well over 600 per 100,000. But obviously we have whole baskets of measures, so it is harder, other than in the review that the Royal Society published last June and in the BMJ paper of just a week ago, to pick out exactly which measures are having the impact. The BMJ found masks and hand hygiene were equal in their impact and actually bigger in their impact than physical distancing. And therefore, to me, they enable people to engage and they enable people who are vulnerable to feel safe and come out, because otherwise those who were shielding are going to be stuck in their houses all over again. And while mask wearing wasn't mandatory in England, it still remained in the guidance of this government if in a busy public space. And I'm sorry, I have to say that that guidance has been undermined by the demonstration on television every day of members on the government benches. Initially, when we came back in the autumn, there were approximately 5 people who wore masks. Then it more than doubled to 14. And after it was being pushed, is about 2/3. But that means about 1/3 of members of the government on the day when mask wearing in busy places is actually meant to be promoted are still not wearing masks. And people will be led by example, not just the Prime Ministers, but every other. I've given away a lot, and there's lots of other people who are waiting to speak. And as for the nonsensical claim by the Leader of the House that you cannot catch COVID from your friends, I have to say words fail me. And that, as you can well believe, is not a common occurrence. It is clear that actually the commonest spread is within households. So if the Leader of the House thinks that husbands and wives and children are not friendly with each other, I really worry about his home circumstances. Now, it is early days, but we should be following a precautionary approach. As Dr. Ryan of the WHO has always said, go early and go hard. In the last 3 waves, the government often delayed making decisions until the problem was proven. I welcome the changes they are making to try and be ahead of the curve this time. But as well as masks, they should advise those who can easily work from home to do so. They should be promoting the hands-face space again to push that to people who've maybe got a little bit complacent. And they should be looking at how to support the installation and improvement of ventilation. COVID is airborne. If you remember before the smoking ban, how smoke used to hang in a pub. If any of you ever worked in pubs, as I did as a student, that was still hanging there the next morning. That is the issue around poorly ventilated spaces. And we've seen it in this House in the outbreaks associated with committee rooms. And just finally, to finish, Mr. Speaker, the arrival of such a variant was inevitable. Basically, last spring, we heard warm words about a global response to a global crisis. But while over 85% of adults in the UK have been doubly vaccinated, it's less than 4% of those in low-income countries, including many who have not been able to vaccinate their healthcare workers. Okay, briefly.
Thank you for giving way. The evolution of an immune escape variant, which maybe Omicron is, does that occur because of a vaccinated immune population or because of a naive population?
Well, I think its emergence in southern Africa would suggest that it is from a naive population. But one of the issues around our complacency and reliance on vaccination here, while allowing very high case numbers, is using Darwinism, you can actually be pre-selecting for vaccine-resistant variants and mutations, because those are the ones that will get a grip. The ones that are vaccine-susceptible will not, because we are so vaccinated. So actually allowing high spread, which means common mutations, is a problem wherever it is. But in the naive populations in the global south, there is a real danger. They don't have testing, they don't have the materials, they don't have genomics, and they don't have vaccine. And therefore the danger is you get a variant that's building up and then eventually will come to Europe, will come to the UK. And sending occasional batches that are almost out of date, as we heard reported recently to the APPG on coronavirus, doesn't allow governments in the global south to prepare and use those vaccines within their date. The UK is still among the countries blocking a TRIPS waiver. And we must realise it's not just a matter of sharing some leftover doses. We need to massively increase global production. And that means sharing intellectual property, sharing technological expertise. Because if anything, this variant should be a reminder that no one is safe until everyone is safe.